Hi everybody, and welcome to our Facebook Live Q&A session. I am Dr. Rami Kaldas at the Kaldas Center, and I'm looking forward to answering your questions and hopefully putting you on the right track to live a better, healthier life. At the Kaldas Center, that's what we go about helping people do every day, and we really enjoy that. We deal with a lot of complicated situations for people from all over who have had real challenges in getting a proper diagnosis and getting relief of some unpleasant chronic situations such as endometriosis or congenital anomalies that have been undiagnosed or just have been untreated. And of course, the challenges of fertility, those couples who have, been in the wilderness of infertility for years and years and seemingly not getting a straight answer what's going on and where they need to go. So I'm real glad that you've joined us tonight to talk about how we can help you with these things. So a special announcement, our next Facebook Live Q&A will be on September 10 at 7:30 p.m. So please mark your calendars. Write down your questions between now and then and have them ready. Before we begin, a reminder that this Q&A is meant for informational purposes. If you have serious health concerns, make certain to contact your doctor. If you would like to contact the Kaldas Center, visit us at kaldascenter.com or call us at 920-886-2299 during our normal business hours. We would be delighted to hear from you. And we are ready to get started with our questions and answers and see what is on your mind. From Carrie, the question is, at what age do signs of PCOS start showing? Is there a cure? Well, Carrie, polycystic ovary syndrome can start showing once a female hits reproductive age. And so you won't usually see it, in the prepubescent time period. But once you start having periods, or not because of the polycystic ovary syndrome, then you can have that. It is a complex metabolic situation. And what's confusing even to a lot of doctors is there's a lot of gray when you think about polycystic ovaries. So you can have polycystic ovary syndrome, or you can have polycystic appearing ovaries and everything in between. So the syndrome is a metabolic syndrome where you have elevated testosterone and androgen levels, and you can be on the heavier side, and carbohydrate metabolism is no good, and or you can simply have polycystic ovaries and have very irregular or absent periods. And a lot of the time when you have polycystic ovaries but without the syndrome, you have just as hard a time getting pregnant because you're simply not ovulating. For example, in Europe, polycystic ovaries are entirely an ultrasound diagnosis. Whereas here, the scientists, the doctors who do this kind of work have more emphasized the syndrome, which actually is a small minority of the people with irregular menses caused by polycystic ovaries. So the fundamental thing is an insulin resistance in one of the cell types of the ovary, and therefore the ovaries are not ovulating regularly, and that can be treated, and the usual treatment is an insulin sensitizer like metformin or glucophage, and that makes it so those cells are more receptive. So for example, if you have polycystic ovaries and you're not having periods, and you put someone on metformin of the appropriate dose in the right way, then about 70% of the people will be cycling right on time every month within 6 months. And half of them will be pregnant within a year if that's what they want to do, all right? And then you can treat the hair growth of polycystic ovary syndrome and the acne with adding a birth control pill if someone isn't trying to get pregnant, and a mild diuretic called spironolactone or spironolactone. And the best treatment for that stuff is a combination of all three: metformin, the birth control pill, and spironolactone. So is there a cure for it? Not necessarily a cure. Obviously, in menopause, the ovaries stop working, stop making all that estrogen, and however, the components of the syndrome otherwise are still present, Carrie. So it is something that needs to be managed, but can very much be successfully managed. Thanks for the question. So from Haley, I saw there's a new endometriosis drug out now, Orlissa. How does that drug treat endo, and why aren't there more endo drugs available? Fantastic question. Why is it we've been dealing with Lupron for decades? I mean, when I did my training back at Stanford back in the 90s, it was just Lupron. And of course there was danazol, the androgen, the testosterone derivative, but it would change people's voice and they wouldn't go back. So Orlissa is in fact working a little bit like Lupron, but the opposite. And this is confusing if you want to really understand why it works. So Lupron is a GnRH agonist, and it like for the first week it actually has a counterproductive effect, and then it works, okay, where it shuts down the ovaries. And other is an antagonist, so it's just directly opposing, okay, and so but ultimately they achieve the same thing, shutting down the ovaries. And therefore, the studies, while they appear promising as far as pain associated with endometriosis, especially after surgery when you're treated with Orlissa and so on, they're really showing some similar side effects. So the hot flashes, the bone demineralization, osteoporosis over the long term. So it has been approved at the lower dose. There are 2 doses. It has been approved at lower dose to be used for up to 2 years consecutively, as long as the side effects are tolerable for someone. However, for the higher dose that's a bit more effective, then you're not supposed to use it for more than 6 months. And that is the way it works. So in a roundabout way, it is working, ultimately having the same effect that Lupron has and similar side effects, but hopefully without the long-term sequela of bone demineralization quite as badly. So, and why aren't there more drugs available? Our research needs to be catching up with that. It's kind of like, why is breast cancer an epidemic in this country? How can it be that endometriosis affects 10 to 15% of women, and it is so misunderstood? And why is it that it takes 9 years on average to get a diagnosis, and seeing 5 different doctors to get a diagnosis? It's pretty shocking considering the millions of reproductive age women affected by that disease. So thanks for the question. From Lisa, does an egg quality play a factor on if your FET is successful or not? Well, in the frozen embryo transfer, sure, the egg quality is going to have an impact, because when they grade those eggs as A, B, C, D, the gamete biologist, they are essentially deciding how normal genetically those embryos are, okay? And so egg quality will impact how normal the embryo is genetically. And as we know from pre-implantation genetic diagnosis, about 65-70% of all human conceptions, in fact, are genetically abnormal. And so when you grow, that's why you lose most of those embryos when you grow them out to the blastocyst stage. And when they are transferring back embryos from eggs that were not of great quality, then this will have somewhat of an impact, and they probably actually won't make it to blastocyst stage. And that's one of the reasons that embryo transfers are done later on rather than the zygote stage, because you don't want to transfer embryos back early on that are more likely not to succeed. So another question from Samantha. My daughter is in high school and has a very bad PMS. I let her stay at home from school a few times last year when it was really bothering her. Should I be worried? Can it get worse? Oh boy, Samantha, it sure can get worse. And so what I would say is it is reasonable to try a low-dose contraceptive pill to try to improve on your daughter's very bad PMS. If it is a physical symptom like severe pain, then you seriously need to consider the possibility of just an excessive release of prostaglandins like teenagers have, or the possibility of teenage endometriosis, especially if you had it, Samantha, because it is extremely hereditary. If the PMS you're talking about is more related to mood and depression symptoms and psychological things like that, then you know there are real neurochemical shifts that happen in the brain cyclically, and you know that can be helped by medications if it's severe. And it sounds like maybe your daughter is experiencing some severe symptoms, and it's worthy of looking into that with either someone who knows, you know, how to manage issues of severe PMS. Obviously, we do that at the Kaldas Center, or a pediatric gynecologist, or a reproductive endocrinologist. And a reminder, if you would like to set up a time to speak with us at the Kaldas Center, call us at 920-886-2299 or visit us at kaldascenter.com. And then the next question is from Nikki. What's the difference between endometriosis surgery with the Kaldas Center versus other facilities or OBGYNs in the area that do a robotic surgery? Well, great question, Nikki. So fundamentally, endometriosis is a systemic disease. One of the presentations of endometriosis, this autoimmune dysfunction called endometriosis, is when you have endometriotic implants outside of the uterus, outside of the uterine cavity. At the Kaldas Center, we do complete excisional therapy. It is removed. It is removed, period. There is no compromise. And so we take the carbon dioxide laser and we remove it. What you need to understand with the robot is only as capable as the surgeon using the robot. So for instance, recently the graduates from residencies have been trying to absorb so much that the literature is saying to us that there's a serious deficit in surgical skill for, you know, OBGYNs who are finishing training in the last 10 years. So for example, most recently, only 12% could do a vaginal hysterectomy by themselves. Only 40% could do an abdominal hysterectomy by themselves. Putting someone behind a big hydraulic machine, the Da Vinci robot, is not going to make them a better surgeon. It's going to put a very expensive tool in their hands that can help them or can hurt you. So, like with everything, I consider the robot just another instrument. It's like a scalpel or like a laser. And the person using it simply needs to know what they're doing. And because of the lack of any tactile stimulation, you can't feel anything with the robot. It's a big hydraulic equipment, a type of machine. It is not, most people think, very well suited for the treatment of endometriosis, with the exception of literally a few people in the entire country, because it is just, you know, it's a rather, even though you can do very fine movements with it, you just can't feel anything. And endometriosis is the kind of thing where it would really help to be able to feel around as well as see what you're doing. Thanks for the question. And therefore, what ends up happening is, as repeatedly as done, people have surgery, they're told, well, this was too close to your bowel, or this was too close to your ureter, or this was too close to your bladder, we couldn't get it. It would be too dangerous. You'd end up with a colostomy. Well, no, you wouldn't. You just have to have someone who's comfortable with the surgery, who knows their anatomy, and who knows how to excise it without that stuff happening. From Ashley, what can be done about endometriosis that was found during a hysterectomy with ovaries left that wasn't able to be taken off cause? Whoa, I just answered that question, and I didn't know I was answering it. And so you've got a situation where very few people are comfortable with the anatomy and with taking out the disease because they're worried they're going to get into bleeding, and then they're going to start cauterizing or burning to stop the bleeding, and then they're going to burn the bowel, or they're going to burn the ureter. And so what you need to do is find someone who knows how to get it out completely without getting into trouble. It's all about how well you've been taught and how surgically skillful you've become. And unfortunately, practice even doesn't make perfect if you never learn the skills. The Society for Laparoscopic Surgeons is having a symposium later this month in New York on what does it take to make a good gynecologic surgeon, because our profession is seriously challenged on that front. So no, you are not a lost cause. You just need to come and have a day surgery and get the stuff excised and then be put on whatever therapy you need to be. You can keep your ovaries if it's completely excised, because if it's completely gone, nothing is going to be left to stimulate with your perfectly fine ovaries, and you don't need to be in menopause. So yes, there is absolute hope for you. You are not a lost cause. Just give us a call at the Kaldas Center. And Lupron therapy is helpful if you do cautery or burning therapy of the endometriosis, but it doesn't do it's of no benefit if you do complete excisional therapy, because it is gone. Thanks for the question, Ashley. And from Melissa, I want to get pregnant next year in August. How soon should I take prenatal vitamins? Hey Melissa, start taking them at least a month before. You want to start taking that extra folic acid, and if there's any neural tube defect like spina bifida in either family, either you or your partners, then you want to take extra folic acid. So instead of 800 micrograms, you want to do a whole 4 milligrams. You can get that in the health food section of any store. You can hardly overdo folic acid in pregnancy. And so, but at least a month before you want to get pregnant. Okay. And so from Kelly, how successful are intrauterine inseminations? Kelly, intrauterine inseminations in and of themselves, by themselves, don't offer a huge amount of benefit in and of themselves. You need to combine it with controlled ovarian stimulation with either oral medications like Clomid or letrozole, or injectable medications like Follistim or Gonal-F. Obviously, with controlled ovarian stimulation with Clomid or the injectables, you do have an increased risk of twins or triplets. And but if there is a male factor component, like there is about 40% of the time, inseminations can definitely help. And you're going to see literature quoting success rates anywhere from 8 to 10% with insemination with controlled ovarian stimulation, all the way up to 15 to 20%, and per try, depending on how severe the male factor is and the circumstances. That said, remember that with controlled ovarian stimulation, you do have that risk of multiple gestation. So you want to know what you're getting into, and you want to be monitored during the cycle so you know how many follicles are going to go when that trigger shot is given. If you're simply doing inseminations with no monitoring and no trigger shot, the literature does not support that as a very effective approach. So the next question is from Jen. I have PCOS. Are there ways to find out now if my 15-year-old daughter has it, or should we wait until she's older? She already has very sporadic periods and only got her period a year ago. Thanks. Yes, Jen, there are lab tests that can be done. You can check an insulin level and see how high it is. It's usually elevated with polycystic ovary syndrome. Hey, and you can also do anti-Müllerian hormone. It's usually pretty high if it's here in your blood work if someone has PCOS. If someone has PCOS, their androgens will be elevated. But maybe your daughter just has polycystic ovaries and doesn't have that metabolic syndrome component, okay? And then an ultrasound would be really helpful to make either diagnosis to see what the ovaries look like. So absolutely. And also, of course, the irregular periods may be affected by other things such as an abnormal prolactin level or an abnormal thyroid level, and those should be checked also. So I would definitely get in to visit with your reproductive endocrinologist or gynecologist who really knows what they're doing with this stuff, because most of them have not had a lot of education in this, or you know, your endocrinologist even. And of course, we're more than happy to see your daughter at the Kaldas Center. So do remember that you can get a hold of us at the Kaldas Center by going to kaldascenter.com or just reaching us at 920-886-2299. I love your questions. I feel like by answering these questions, we're really fleshing out why day in, day out, I have the most amazing patients from literally around the country, around the world sometimes, coming in here, little old northeast Wisconsin, you know, Appleton, Wisconsin, with just frustrated because they have just not had the light shed on the situation. This is not voodoo. The questions you're answering are fantastic, but when you don't get straight answers with informed you know, knowledge, and then you start thinking it's all voodoo and that nothing can be done. But there's all kinds of things that can be done. So from Amber, the question is unexplained infertility an actual diagnosis? If so, is there any treatment that is guaranteed to help with unexplained infertility? At what point of treatments not working do you try something else or stop trying? Well, that's a multifaceted question, Amber. And so unexplained infertility is simply, yes, it's a diagnosis because we don't have the complete knowledge of reproductive biology. So, for example, there's a lot of work that's been done in the last 30 years on cellular biology. So, for example, what is happening in the cytoplasm, the fluid, inside the eggs, okay? And what's happening with the energy sources called mitochondria in those cells. And when there are certain eggs and with a particular kind of fluid that are not fertilizing very well, or they fertilize and they don't go very far. So then you end up with a situation of unexplained infertility that's rather challenging and only being dealt with experimentally right now in trying to treat it. I just recently read a study out of Japan with 20 patients like that. However, most of the time, unexplained infertility is because there is an answer, but it just hasn't been found because people haven't looked in the right place. Now, ultimately, after 3 cycles of controlled ovarian stimulation with oral medications, 3 to 4, then, you know, up to 6 at most, you don't keep trying with Clomid. After 6 cycles, if it hasn't worked, it's unlikely to work, and you need to move on to something more proactive. Make sure all the baseline labs as recommended by the American Society for Reproductive Medicine have been done, and there is not a shotgun approach happening. Shotgun approaches don't work very well at all. So you just have a very informed, methodical approach, stepwise manner, least invasive, least costly, to more invasive, more costly, and you will succeed 3 to 1 before you ever even need to think about IVF. Is unexplained, okay, very good. And that's when you go. Okay, from Liz, can menstrual cramping get worse after having pregnancies? Is the myth that dysmenorrhea improves after pregnancies? Is it a myth? Yeah, dysmenorrhea does not really improve after pregnancies. Most of the time it does get worse because when the uterus expands 1,000-fold by volume to accommodate a fetus, a child, then it shrinks down to the size of your fist within 6 weeks. Then the lining folds into the muscle of the uterus and it creates something called adenomyosis uteri, or adenomyosis. And that actually, then you have bleeding of the endometrium into the muscle of the uterus, and people's cramps get worse. Adenomyosis is a kind of endometriosis. It's endometriosis of the muscle of the uterus, and it's more common the more children you've had, especially if they were C-sections. So thanks for that question. From Lisa, Lisa would like to know how big follicles have to be for IUI or the preferred size. All right, it depends on the medication used, Lisa. So if you're using oral medications, anywhere between 16 and 24 millimeters is reasonable. And if you give a trigger shot like Ovidrel, okay, and to mimic that luteinizing hormone surge, then you're going to have all of those follicles go, and they're going to give you an egg. And that's the risk of multiple gestation. okay? But with follistim or Gonal-F, the injectable medications, you want those follicles to be up to about 20 millimeters, okay? You don't need to wait until they're 24 millimeters. Otherwise, you're gonna have a much higher chance of ovarian hyperstimulation syndrome because you're gonna have the smaller ones being recruited also. So you'll get plenty between 16 and 20 with the injectables. And that's how big they should be depending on the medication. And so, great questions. From Melissa, I'm very thin, 95 pounds, 4'10". I would like to know, what are my chances of having twins? My fiance has twins on his side and I have twins on my side of the family. Well, there is a genetic component for identical twins, you two. If they're fraternal, you don't have an increased risk, but if they're identical, then you do have an increased risk. On the basis of your size, that is not indicative of how likely you are to have twins, only that if you do have twins, they're more likely to be 4'10" and weigh 95 pounds also, if they're girls. Okay, so from Anne, my husband and I have 2 kids already, but are struggling to have a third. Are there infertility issues that are more common after you have already had kids? Yes, Anne. You're more tired and too sleepy in order to have sex, in order to have more children. However, beyond that, it's a matter of life goes on, life is dynamic. And for example, varicocele can happen to your husband. So that's where they get varicose veins around the testicles that can raise the temperature and cause sperm count to go down. It could also be that with yourself, if you had C-sections, you could be scarring. Also, usually after having a few children, you're obviously by definition not as young as you were when you had your first children. And the further along you get, the more likely you are to develop endometriosis because you've had more cycles and retrograde menstruation, that backwards flow of endometrium that all women have, but that endometriosis sufferers, even the ones who are asymptomatic, since 25% of all endometriosis sufferers actually don't suffer. They're asymptomatic, but they still have it. And then that inflammatory process will reduce your chances. And so, yes, there are things that do happen as you age that can cause you to have decreased fertility, in addition to simply aging. If you're, 35 years old compared to 25 years old, well, your chances of embryos being abnormal are going to be a little bit higher, and you probably aren't even going to know that you're getting pregnant. You may be conceiving, but still having a period. They're not implanting, and you don't even know you were pregnant. And so all of those factors can play a role as you age. So then there's another question from an anonymous questioner. How often is infertility a male problem? My husband and I are trying to have a baby, and he doesn't want to get tested. Ooh, shame, shame, shame. It's never a person who's infertile. It's always a couple who has fertility issues. And so it's about 40% at a time. And it is a big drag to pump someone full of drugs, for a year or whatever it is, and then find out that it's a male factor that could have easily been addressed. And what needs to happen is that your husband obviously is concerned that he might be the issue, and he needs to be informed that he is no less of a man and he is no less macho if he has a low sperm count. And I think that is really key. That is not related to how much testosterone you got. So I've had big hairy guys who, are, it's like Paul Bunyan there, who have low sperm counts, and they end up having children, but sometimes those sperm need to be concentrated. It has nothing to do with masculinity. And so I think if you explain that it's a thing that both of you are going through, and it is in no way, shape, or form a statement on his masculinity or belittling in any way, then he won't have a problem getting tested, so you guys can have whatever children you want to. So thanks for the question. So from Allie, is folate better than synthetic folic acid? I have seen it advertised as better, able to be absorbed better, in more natural prenatals. Ultimately, it's metabolized to the same thing, okay? And so folate, folic acid, they're used interchangeably. Obviously, they're different forms of the same thing. So it's arguable whether one is more effective than the other. As long as you're taking about 1 milligram of either one, you should be fine. 4 milligrams of either side of the family has neural tube defect in it. But of course, you know, natural, holistic remedies will suggest things that aren't necessarily supported by science, but either one is fine. Okay. So from Jennifer, how indicative of infertility is AMH level? If a level is low, 0.7, is pregnancy still possible? Would medications such as Clomid or a trigger shot be useful? Or would IVF be required? Oh my gosh, I've had people with as low as 0.2 or 0.3 AMH get pregnant on their own when they were 38 and 39 years old. And so, yes, it is indicative, but it is not absolute. So if you can get someone to ovulate with low AMH level, then the egg quality is not indicated by that AMH level, but rather how hard it's going to be to recruit those follicles. Therefore, 0.7, not too bad. If it's 0.7 and you're 35, I'd say we are going to have a better chance than if it's 0.7 and you're 45. And so I think that obviously there are a multitude of different things that can affect the ovarian reserve, which AMH level indicates. It may be worthwhile getting an antral follicle count and seeing if you have more than 7 of those, and then doing a trial cycle. But I would fully intend that you would get pregnant with cycles, intelligent cycles of controlled ovarian stimulation with Clomid and trigger shots, with or without timed intercourse, or insemination, with or timed intercourse and insemination, depending on the whole picture. Obviously, this is just one factor. One would need to look at the whole picture, and we would be happy to help you with that, Jennifer. It looks like we're out of time already. My gosh, I must like listening to my voice way too much, because every time it like goes by so fast. I think surely we've got half the time to go. But thanks for everyone who joined the conversation. If you didn't get your question in, we'll follow up with with you in the next few days. A reminder that if you'd like to speak further with us, just give us a call at 920-886-2299 or visit kaldascenter.com. Would love to get more of your questions. It's been really fun. Thanks for the great questions. Remember, our next Facebook Live Q&A will be September 10 at 7:30. Look forward to seeing you then. As for tonight, thank you again for spending your time with us, and we hope you have a wonderful evening. Bye-bye.